So I'll go ahead and start, at least going through the preliminaries. So hi everyone, my name is Noel Watson. I'm a member of the organizing committee of the Global Health Supply Chain Summit, and welcome to track 6, where we're looking at supply chain improvements that may have been motivated, may have had their genesis as a result of the pandemic, but they're here to stay because their benefits have proven to require that. And specifically, my understanding, we're having 2 abstracts, but the first one is actually a series of presentations entitled No Going Back, Integrating Supply Chain Adaptations from COVID as Routine Practice. We're having multiple presenters listed here. And just out of curiosity, for this particular series of presentations, do you have, and anyone can speak up at this point, do you have your own facilitator, or would you like me to still be somewhat doing a facilitating role with respect to this presentation series?
Noel, this is Edward from JSI. So we had pre-recorded the presentation, and our understanding was you were just going to run the recording from your end.
Okay.
So that's what we have teed up. Just as a little note, the Prezzo runs for about 50 minutes, which I think is the time we have allotted. So if people have questions during the presentation, please post them in the chat. And most of the, if not all of the presenters are also online here, and we will try to respond to those questions as we go, as I don't think we'll have time for a Q&A afterwards. Our apologies for that.
Okay, excellent, Ed, I appreciate that. So as I just pointed out, this will be a presentation that run for the full 50 minutes. And if you have questions, please post them in the chat. The presenters are here and they will do their best to answer your questions. Then at the end of that presentation, we'll go to our second presentation, Malawi Ministry of Health and Partners, adapting the public health supply chain to swiftly and effectively distribute COVID-19 vaccines. And I just want to check if one of the presenters is here. I think this is an in-person presentation. So just checking if Charles or Denver or Danielle or Mfatso are here.
Hi, this is Charlotte Stein from the same organization. I'm actually just trying to grab one of them to make sure that they're joining. They know that they're supposed to be here, but hopefully they'll be here momentarily.
Okay, I appreciate that, Charlotte. Well, they have 50 minutes pretty much to get here. But thanks for that update. So without any further ado then, I'll let the video play. During the last presentation, if you have questions, you can use the reactions button from Zoom to raise your hand, and I can call on you and you can ask questions. But as I mentioned during the first presentation, questions should be put in the chat and the presenters will do their best to respond. Okay, and here. We'd have the first presentation.
Welcome everyone, and thank you for being with us today. My name is Edward Wilson, and I am the moderator for today's panel. I'm the director of John Snow Incorporated's Center for Health Logistics, as well as the director of the Partnership for Supply Chain Management, a JSI affiliate. This presentation is recorded, so we will not take questions during the presentation, but the presenters will be available after the presentation to take any questions that you might have. If you do have questions, please hold them till the end of the recorded presentation. The session's topic, No Going Back, reflects that the pandemic has caused us to rethink how we manage our supply chains, and some of the changes we made out of necessity have, in fact, become new ways of doing business because they help increase agility, resilience, or effectiveness. Today, we're going to hear from 3 speakers who will offer 2 local and 1 global perspective on the adaptations they have made due to COVID. I will introduce all of the speakers at the beginning of the presentations and then hand over to them one by one as we move through the presentations. Each presentation will last about 10 minutes. After that, I will ask each panelist 1 or 2 questions depending on time, and then open the floor to questions from you, the audience. So I have the pleasure of introducing our 3 panelists for today. They are Johnson Anyona, is the supply chain lead on the Access Collaborative project and a supply chain analyst at the InSupply Health company based in Kenya, Nairobi. He has over 7 years of professional experience in public health supply chain management of essential medicines and medical supplies at facility, subnational, and national level. Johnson is passionate about health system strengthening, use of data for decision-making, building resilient supply chains, and promoting equitable access to quality, life-saving commodities in low-resource settings. He holds a bachelor's degree of pharmacy from the University of Nairobi and a master's degree in health supply chain management from the University of Rwanda. Gamariel Simpungwe is a registered pharmacist by profession with over 19 years of work experience in the public sector in Zambia and partly in South Africa. He has worked in public health with a focus on supply chain management in Zambia since 2006 at various technical and senior management levels. He was among the lead technical advisors in the design and implementation of the Zambia National Logistics System, which encompasses ARVs, essential medicines, and medical supplies, malaria, and reproductive health, and is now incorporating anti-tuberculosis drugs and vaccines. He is currently Director, Data Analytics and Transition on the Electronic Supply Chain Management Information System project, a USAID-funded project implemented by John Snow Health, mandated to implement the Electronic Logistics Management Information System in Zambia. Finally, Suzanne Veit is the Pool Procurement Mechanism Project Director at the Partnership for Supply Chain Management. Suzanne oversees all PFSCM's procurement and logistics services for the organization's largest client, the Global Fund. Suzanne has a wealth of global and in-country supply chain management experience and has worked in both the public and private sectors. Suzanne comes from the US, but joins us today from Amsterdam in the Netherlands. And we'll now start with our presentations. We'll turn off our cameras during the presentations to minimize any bandwidth issues and turn them on again for the questions. We begin with Johnson from Kenya.
Thanks, Edward. Hello, everyone, and thanks for joining us. Next slide. So I'll begin with a bit of background on the study that we did. In July of 2020, the Reproductive Health Supply Coalition, with technical assistance from JSI, undertook a 6-month rapid assessment of the effects of COVID-19 on the SRH supply chain, with the goal of generating evidence to help the SRH community better understand the disruptions occurring in the supply chain as a result of the COVID-19 pandemic, the effects of this disruption on the supply chain for SRH, and actionable solutions that can accelerate opportunities and address the weaknesses identified. We looked across all categories of products within SRH, acknowledging that it's quite a diverse group of products, that is family planning, maternal health, menstrual hygiene, and STI-related commodities. Our approach assessed the various functions of the end-to-end supply chain, from manufacturing to service delivery at the last mile. Our data collection and analysis was very collaborative and opportunistic, leveraging on existing data and analysis, including public data sources, partner surveys, key informant interviews, and other relevant inputs. We also interviewed and collected data from a multitude of partners working at the global level and 3 other countries in depth to provide context and highlight the effect of COVID-19 on the SRH supply chain. The data collection occurred between August to October 2020. The findings that I'm going to share are a snapshot of what we learned from the experience in 2020 in one of the focus countries, that is Kenya. Next slide. In Kenya, we got our first case of COVID-19 on March 12th of 2020. As the cases increased, the country went into a reactive phase where stay-at-home messages followed by curfew and restrictions of movement in some parts of the country were issued by the government. This resulted in a lower levels of care seeking. There were limited health facility staffing, and some staff were reassigned to COVID response. Some health facilities were converted to COVID isolation centers, and curfew hours limited the hours of operation for warehouse staff. The initial focus, as was the case in many countries across the world, was self-preservation. The attention and priority shifted to procurement of PPE and ensuring sufficient COVID-19 related services. If I can read a quote from one of our KIs that you're seeing on the screen, they told us that the demand that came with coronavirus really shifted everything. Basically, family planning was third place, if at all it was on the table. There was a need for an urgent response and preparedness for COVID-19, and family planning was not even considered a priority at all. And then there was HIV programming, TB, which we knew was also to be disrupted. So family planning was not considered an emergency at all. Following the shift to more of a crisis management phase as the pandemic continued, we observed the following effects in the SRH supply chain. In procurement, international procurements were delayed. There were higher freight costs and higher product costs in some cases. For example, we got to learn of a marginal increase in the price of oxytocin. In inventory, healthy stock positions helped mitigate against delays, but also shipments appeared to continue to be received. Kenya's central medical stores has a high max mean inventory level of 16 to 22 months of stock. So where there were delays, it was a matter of days or weeks and not months. In terms of distribution, our central medical stores, KEMSA, acquired the status of essential service provider, meaning distribution wasn't affected, though order fulfillment was slightly affected due to the reduced shifts of operation. Under demand, the lower levels of care seeking witnessed in the reactive phase recovered to pretty much pre-COVID levels, if not higher. As you can see on this graph to the right of your screen, we analyzed changes in couple years of protection derived from consumption data to evaluate the effect of COVID. There was a brief initial decline in CYP for long-acting reversible contraceptives, such as IUDs and implants, but this returned to levels comparable with those before COVID. For short-term methods, that is pills, condoms, injectables, they were in line with pre-COVID trends. Next slide. In our assessment, we rigorously looked at stock status, consumption, and stock out rates before and during COVID. We also included key informant interviews from public, private, and social marketing organizations. Although you are interested in data on family planning, maternal health, abortion, STI-related commodities data, in Kenya, there was limited data for products beyond family planning. There was also limited quantitative data in the private sector. As a proxy for equity, we analyzed subnational stockout data to determine if some geographies were more likely to be stocked out than others. We discovered that there were no unusual trends observed during the crisis management period. That is, regions that were more likely to be stocked out after March 2020 were also those that had had higher levels of stockouts in the past. So overall, there are positive findings in terms of short-term disruption to services. For instance, if you look at this graph on the left hand of your screen, it represents the total modern contraceptive prevalence rate for all women of reproductive age in Kenya. And the dark blue shaded part represents the period that the pandemic began. We noted that despite supply disruptions and dips in service levels in the early months of the pandemic response, our MCPR rates increased in the crisis management period. This is consistent with data reported by the PMA 2020 survey, which showed that more women switched to longer acting methods and moved away from traditional or no methods at all. Next slide. That Kenya's SRH supply chain was able to largely brave the pandemic was not just by chance. There were some mitigation efforts put in place by government and stakeholders, and I'm going to highlight 3 of them. First, the government of Kenya quickly developed and disseminated RMNCH guidelines. Therein were strategies aimed at ensuring continuity of care in the context of COVID-19. For instance, adjusting facility level minimum stock levels from 4 to 6 months of stock, prioritizing less skill-intensive family planning products, such as pills and condoms, and multi-month dispensing of family planning methods. Second, a directive that SRH services are considered essential services and their staff essential service providers allowed work to continue and facilities to remain open during curfew hours. Third, there was innovative use of technology to inform distribution of SRH products to where they were needed most. So platforms such as WhatsApp, Zoom were used for virtual data review meetings at a time when in-person meetings were strongly discouraged. Next slide. So I'd like to finish by highlighting that there are some pandemic-induced operational changes which have endured post-pandemic. I've mentioned that SRH services were classified as essential services, ensuring continuity of care, and that is in place to date. And then there's been increasing use of the virtual platforms for data review and information exchange to inform supply chain actions. There's been increasing use of direct-to-consumer models for service provision and distribution, such as e-pharmacy, telehealth, and telemedicine. And then we still continue to maintain healthy inventory parameters at both central and facility level. Thank you for your time and attention. And as I had closed, I would just like to acknowledge that these findings that I've shared represent only a small part of a significant amount of work that was done by quite a number of team members at JSI, with input from many participants who contributed to the study from the SRH space. You can access the full report and roadmap of this work in both the Reproductive Health Supplies Coalition and JSI website. And the report is titled Building Resilient SRH Supply Chains During COVID-19 and Beyond. Thank you. Back to Edward.
Thanks so much, Johnson. Really interesting work, and so exciting to see that service levels and utilization levels, in fact, did not drop thanks to the hard work that was done in Kenya, and really interesting to see some of the operating models that persist even after COVID in terms of service delivery modalities, the use of technology to facilitate collaboration and review, and the diversification of channels through which consumers can access products and services. Really interesting. Thanks so much. So now I'll hand it over to Gamariel to tell us about his experience in Zambia.
Thank you, Edward, and hello to everyone, and thank you for joining us. I will run you through the different stages of how the logistics management information system in Zambia has evolved, and with the impact of COVID-19 and how we have managed to come out of challenges that we experienced. So just a brief background, as far back as 2006, the Ministry of Health, with support from donors, particularly USAID and the Global Fund, undertook to design the logistics system for antiretroviral drugs. At the time, Zambia experienced significant expiries and lack of visibility in terms of commodity availability at facility level. And also we didn't have information on what was being consumed and if there were any losses or adjustments in the field. Following the rollout of the ARV logistics system, the ministry took the lead with support from stakeholders to undertake an evaluation of the system, and results of which indicated very good performance. We had reduced stockouts, we had increased visibility through the information that the system was providing. We also had increased number of decisions that were being made based on the data that was coming from the facilities. And these results actually were so impressive that it urged the government to look at how best they could utilize the developed system to also take care of other other areas which would support the antiretroviral therapy for the clients, and specifically targeting opportunistic infection and laboratory supply chain. So the ministry expanded that to cover these commodity areas. And for essential medicines, this also encompassed reproductive health, as well as malaria. And at the time, tuberculosis, anti-tuberculosis drugs, and COVID vaccines in general had not yet been incepted into the mainstream supply chain. Of course, COVID-19 tested the health sector in general, and particularly the supply chain system in Zambia. And some of the key challenges that were identified were reduced capacity for the central medical storehouse, or warehouse rather, to find, pick, and distribute commodities on time. This was as a result of increased demand from the facilities. Also, the procurement was also challenged in the sense that the procurement pace was not meeting the demand, the increased demand that was being experienced. Of course, the central medical warehouse had its own internal operational challenges to be able to deliver on time. It was a capacity issue. And so the donors stepped in and provided 3PL to help alleviate those challenges. And so because of the urgency of COVID-19 and the need for the ministry to undertake new procurements for commodities that had not been procured or managed in Zambia, and have those commodities distributed to closest possible to the users, the ministry decided to develop or design a parallel logistics system, and with the primary objective of ensuring commodity provision at the last mile. Of course, part of this is the challenge of, part of the reason that the ministry was compelled to look at creating a parallel system is that they felt that in the current format, the logistics system was not able to meet the demand for commodities at the lowest level. And so the approach, in a sense, was more of addressing the effects and not focusing as much on the causes. Next slide, please. So here you see the design of the what we call the COVID-19 parallel logistics system on the left here, and you see the green encompasses both the Central Medical Warehouse, which is called ZAMSA, it's abbreviation for Zambia Medicines and Medical Supplies Agency. And to the right, to the left of that box, we have the ZNPHI. ZNPHI is the Zambia National Public Health Institute. Now, this system that was created by the ministry with support from partners was basically a push system. And reorder quantities were determined by the Zambia National Public Health Institute. Now, in this design, you will note that only 18 facilities were earmarked to be recipient of COVID commodities. And this was attributed to the fact that, first of all, COVID commodities were in very, very short supply. And so it was very difficult for the ministry to have a handle on who gets it, where it goes, who gets to utilize it, and what it's utilized for. So by limiting it to the 18 facilities, they felt a bit of more control in terms of utilization of these commodities. Now, remember, in my preamble, I spoke about the issue of getting commodities to the last mile very quickly. and with the challenge of ZAMSA not being able to meet the distribution schedules on time. So the ministry decided to incorporate the Provincial Health Office, which previously was designated as a supervisory level, to become a storage and distribution authority. So which means ZAMSA would pass on that responsibility of storing and distributing commodities to the last mile to the Provincial Health Office. The system was not designed to actually use logistics data to determine resupply. So that requirement was not needed, was not demanded of the health facilities receiving these commodities. And then because of the urgency of the need to get these commodities downstream, the ministry also directed ZAMSA to prioritize all orders that were for COVID-19 commodities over any other commodity area, be it essential medicines and laboratory. So key outcomes of this parallel logistics systems basically were that because of lack of data, the ministry wasn't able to ascertain the commodity status at facility level. So we did have a lot of stock imbalances. And so even decisions that were made were not made based on data. So even when ZNPHI made the allocation list for implementation by ZAMSA, it was made more using health statistics rather than consumption data. Of course, with the limited access for COVID-19 commodities to other areas beyond the 18 designated facilities meant that health workers did not have protective materials to prevent them from contracting COVID-19 when dealing with patients at the lower levels. Of course, the stockouts, because of the prioritization of COVID-19 order processing within ZAMSA above other commodity areas, resulted in increased stockouts for essential medicines, and this included antiretrovirals, anti-malaria commodities, reproductive health, as well as laboratory reagents. We also noted that the inclusion of a PHO resulted in a bottleneck because PHO was not originally designed to store and distribute. And so they were incapacitated in terms of storage space as well as logistics to distribute commodities to the last mile, and also human resources as well. And then one very key issue that also was identified was the issue of the system being unable to identify or distinguish between use of commodities for COVID-specific interventions or non-COVID related interventions. As you may know, some of the commodities are cross-cutting, could be used in both COVID and non-COVID commodity, COVID-related illnesses. The challenge with this is that some of our donors that we have in country had received funding specifically to target COVID-19. Now, because we were unable to distinguish between the two, it became a bit of a challenge for them to show impact in terms of the funding that they're providing specifically for COVID-19. Next slide, please. So after careful consideration, the ministry with stakeholders decided to collapse the parallel system into the national logistics system. Just a bit of a background of the national logistics system. This was created with the full participation of the wider supply chain stakeholder group. And this took, in developing this supply chain, it took a couple of weeks. I think we're about 2 months in just designing because of the consultation and the different interactions that were involved. This system is designed to be a pull system where facilities would report on a monthly basis the 3 essential data items. And that is what would be used to determine resupply moving forward. And even after this system was implemented, evaluations were done every after 2 years to ensure that the current situation was actually, or rather the system was actually meeting the need for the current situation, taking into consideration the changes in epidemiology of disease in Zambia. And as you know, Southern Africa is one of the worst hit, if it's the worst hit region in terms of HIV infections. So it was important for us to periodically revisit to make sure that the design still remains valid. Excuse me. And with the system, this provided for increased accessibility for COVID-19 commodities, as opposed to previously when the ministry would not have clear visibility of what's happening with regards to COVID-19. And so once collapsed into the system, access to COVID-19 commodities was expanded. So now all facilities are able to access COVID-19 commodities and medicines. And also with this system, because the reporting is based on commodity area into the electronic system, we're now able to distinguish usage between COVID and non-COVID commodities. The system also provided the ability to the ministry to be able to identify what specific weaknesses are existent, as opposed to previously when the system was actually questioned. The whole system was not was questioned to whether it was valid or not, and then replaced with a parallel system. But by using the standardized national logistics system, the ministry is able to identify whether it's a procurement issue, it's a warehouse issue, or a distribution issue that is causing a bottleneck, resulting in commodity and availability at the last mile. Remember that the ministry in the previous system prioritized order processing for COVID-19, but under the national logistics system, all commodities are actually processed at the same time. So as opposed to prioritizing COVID-19 resulting in delays in order processing for the other commodities, the process is now integrated, meaning that human resources, warehousing, distribution is now being used efficiently to manage supply chain. And then, of course, very key to note, one of our key learnings out of this is the issue of appreciating the agility of the supply chain. What we noted during our review was the fact that the core team, the original core team that was involved in designing of the national logistics system has since moved positions. As people have moved out, have retired, or moved on to work in other sectors. And so the historical knowledge of how we arrived at this system has, in a sense, been lost because of attrition. And then, of course, we also noted that there's need for continued educating the new members of staff who come on board to actually understand and appreciate the agility and robustness of the system. And then very key learning from this experience over this past few months is that it's very important that when a new commodity comes on board, that it's important that you support the current system to be able to manage it. And if there are any challenges that are being faced, you enhance the system to actually respond to it, because it cost us quite a loss in our gains when we moved from the national system to create a parallel system, because resources were shifted and it took time for people to be trained in order to understand how the system works. And at the time, the need for commodities at the last mile was immediate. That would be the end of my presentation. I will hand it back over to Edward.
Great, thanks so much, Gamariel, for that really interesting overview of the Zambian national logistics system and how you coped with the arrival of COVID commodities, and how by increasing investment in the agility and resilience of that system, you can respond to both the current pandemic and hopefully to any future emergency response needs as well. Great. And last but not least, I will now turn it over to Suzanne.
Thank you, Edward. Hello, everyone. Thank you for joining. I'm looking forward to sharing our experience in adaptations in managing global supply chains as a result of the COVID-19 pandemic. Next slide. So a little bit of background about PFSCM. We are a procurement service agent and 4PL, supporting donors and governments by procuring health products for low and middle income countries, shipping predominantly into Africa. Through our experience, we know that public health supply chains for low and middle income countries are already long, complex, fast changing, and require specialized skills. COVID-19 has further complicated these supply chains and the requirements to manage them. Working in this domain for more than a decade, PFSCM has dealt with unique challenges before, things like abrupt legislation changes, disasters, theft, things of that nature, and we were able to leverage this experience to overcome many COVID-19 supply chain challenges. At the time the pandemic hit, PFSCM was already undergoing a transformation. We were transitioning from primarily procuring pharma products to medical devices, which is a completely different environment. Our critical decisions then, as a part of that transformation, have become part of the day-to-day now. So agility and adaptability have become the foundation for managing and operating in our new normal. The pandemic also accelerated some internal initiatives as well. So things like our product catalog and the implementation of our new supplier relationship management tool allowed us to scale up quickly and effectively, deepening our experience and knowledge of the diagnostic market. And this was really critical given that we were now supporting COVID-19 diagnostics, which were brand new to the marketplace. Next slide. So some initial challenges we faced, which were common across supply chains and still remain to this day, were issues such as supplier delays in product availability and increased lead times for production. Also a lack of visibility into supplier tiers, meaning their suppliers, to ensure diversification and risk mitigation. We also saw increased globalization resulting in much longer supply chains. And finally, the need to rapidly onboard new COVID-19 suppliers and products. As I mentioned, these products were new and even now continue to evolve. So quality assurance and due diligence have become crucial to ensure we're sending quality products to recipients on behalf of the global community. Ways we've adapted to manage these challenges have entailed things like working with recipients and our logistics partners to develop strategies to expedite shipments and make up some of the time from supplier delays. Previously, this would have been handled more as an exception management activity, but has become more routine now, given that these delays persist even to this day. We've also increased our supplier engagement and now communicate at a higher level with decision makers directly. We do this by sharing information regarding future requirements as much as we have visibility into them, and aligning on operational rules of engagement and expectations to ensure a tighter partnership whenever possible. To improve visibility and supplier mapping, we also implemented a new supplier relationship management tool called Kodiak. This tool streamlines onboarding and provides insight into suppliers' activities. This is especially valuable when dealing with hundreds of manufacturers and their authorized distributors supplying thousands of medical products into the countries we support. So working with funding partners, we're also encouraging recipients to place their orders further in advance to give us greater visibility to suppliers to mitigate the long lead times. So even if the products may not be needed for many months, having that visibility to be able to plan with the suppliers so the product can be available when needed is crucial to really mitigate some of those longer lead times. Next slide. In the area of logistics, PFSCM has relied on its 4PL model to overcome the logistics challenges caused by COVID-19 lockdowns and restrictions. So the team has leveraged its years of experience to quickly find and onboard specialized third-party logistics partners who could assist us in moving time and temperature-sensitive products, including the COVID-19 diagnostics. We increased the use of charters and shared cargo space with fellow PSAs, ensuring the service continuity of various health programs. We also partnered with insurance technology company Parcel to implement data loggers in all of our cold chain shipments. So with COVID-19 vaccine distribution putting further pressure on the cold chain shipment process, every shipment is critical and organizations cannot risk losing any temperature controlled or cold chain shipments to distribution and handling incidents, which in our experience is one of the most challenging parts of the supply chain. And finally, we're more proactively sharing volumes and projected volumes further into the future than previously shared to better plan space requirements and ensure transport availability when shipments are ready. Now, again, this is a very delicate balancing act because when we're sharing this information, if those volumes don't materialize, there can be an impact there as well. So it's very important that we're staying in close coordination with these partners. to make sure that as any of this information changes and adjusts, we're informing them immediately to make sure we can mitigate any adverse impact. Next slide. So wanted to share some specific examples of some of the different activities that we've executed over the last year and actually 2 years at this point. One example of this mitigation activity we wanted to highlight was around a delivery destined for Malawi. So the shipment we were managing consisted of 75 tons of cargo, and we were able to offer the remaining space in the charter to a peer organization who had the same pressing issue and need to get life-saving products into Lilongwe. The shipment contained a mix of fragile, frozen, cold chain, and other temperature-sensitive products. By sharing the space and partnering with this peer organization, we were able to also reduce the overall cost to our client, the Global Fund, and ensure delivery of these life-saving products into Malawi. So it was a win-win situation for both organizations and has been an opportunity that we've repeated at least one other time to ensure that we can deliver goods in an effective way. Another shipment I wanted to highlight was destined for Mongolia, which is another challenging country to deliver into, as they've had lockdowns for extended period of times, which has prevented getting any kinds of shipments into the country. So we partnered with our logistics partner, Logistics, and we were able to negotiate and engage with the Mongolian Ministry of Health and the State Emergency Commission to obtain special permission for a charter flight to land and deliver much needed medical supplies into the country. And these are just a couple of examples of the high level of coordination and engagement and execution that has become the new norm due to the pandemic. Activities that were more exception-based have become the standard way of operating now, as we're continuing to navigate the constantly changing environment we now find ourselves in as supply chain professionals, and are still dealing with to this day. We don't really see an end in sight, so a lot of these changes we're putting in place as our new normal, our new standard way of operating. It is at a much higher level of coordination, but has really supported in being able to make sure we can still meet the needs of our client and the countries that they're supporting, providing these life-saving products when they need them. So with that, I want to thank you for your time, and I will turn it back over to Edward.
Great. Thanks so much, Suzanne. Really interesting and informative, and the focus on what you might call supply chain best practices or supplier and 3PL diversification, collaboration and communication and engagement up and down the supply chain, and then really focusing on providing improved visibility to all partners in the supply chain. Really great stuff. Thanks so much for that. So thank you to all of the panelists for your stimulating presentations. And as we have a few minutes, I'm going to ask each of you a question or two before we open it up to the audience. And I will turn my camera back on. So let me start with Johnson. So Johnson, what are one or two of the biggest opportunities you see at the country level to make SRH supply chains more resilient based on what we learned during COVID-19? And you are on mute, Johnson, if you are responding.
Oh, sorry. Thanks a lot, Edward, for that great question. So the COVID-19 pandemic was a good test of whether our supply chains are resilient. And one of the areas that has huge potential to ensure that our supply chains are sustainable and resilient is on real-time end-to-end data visibility. So in Kenya, the logistics data from facility level is not real-time. The logistics data, once submitted, is only accessible on the National Health Management Information Platform a couple of weeks after it's been reported due to a paper-based reporting at the lower levels, the lower facilities. And then again, the central and regional stores are siloed from each other. This makes it hard to readily visualize and use logistics data at all levels, which is, as we noticed during the pandemic, is really crucial to sense changes in demand more quickly to be able to adjust and make prompt decisions. Another opportunity that we also came across is actually one of the limitations that we faced, which is on data quality. At Supply Health, my organization, we support subnational data review teams to look at their family planning and immunization data. And one of the indicators that we track is the variance between the ending and beginning balance of their stocks. And this indicator assesses the quality of data. So there is still a lot that needs to be done to improve the quality of data through either capacity building, data quality audits, regular data review meetings, so that we are able to quickly pick out these discrepancies of data. And we are doing that in a few counties, but that data use culture and data review needs to actually be institutionalized nationwide. So the two opportunities that I'm seeing is on investing more in data systems to make them real-time and visible from end to end, as well as institutionalizing a data use culture for decision making. Thanks,
Great.
Edward.
Thanks so much, Johnson. Really important and perennial supply chain issues. So yeah, something that we've been working on for many years, and I think with the pandemic has become just even more important. So thank you for highlighting that. Next, let me turn to Gamariel. So Gamariel, you talked about the parallel system and the change to the, and then the switching it to the existing system. So maybe you could reflect for just a minute on what assumptions were made in setting up the parallel system, and then how valid those assumptions ended up being.
Okay. So very, very good question, Edward. Thank you. So one of the key issues that we noted when the pandemic hit is that the country, the Ministry of Health, was experiencing some challenges in terms of stock imbalances at facility. And at the time, what they identified were the causes of that was capacity issues with the Ministry of Health owned central medical warehouse. Now, the issue was that the pandemic was upon us. It was an emergency. We needed to get commodities to the facilities. So then they were looking to find a quick fix solution to ensure that commodities are made available to the last mile. And at that point, it seemed plausible. I mean, it seemed like the best solution to go for the parallel system, because that way they would be able to have better control, and instead of depending on some of the, or rather having to face the challenges with ZAMSA, they'll be able to manage to get commodities to the last mile. But hindsight, I think it's a lesson for the ministry and the stakeholders to actually look at having to address the causes of the challenges that we're facing, more so than to put a band-aid to address the issue, so to have commodities available. And so this is a lesson that we all as stakeholders have learned. And also important to also note is that because of the sort of the frenzy, the panic, we forget the fact that the national logistics system was designed on the premise of addressing an epidemic. Remember, at that time, HIV was ravaging the Southern African region. And so we needed to come up with a robust system which could be implemented in a way that it also factors in a scale up in an event that the epidemic became expanded or became bigger. The system would still be able to absorb that shock. And so moving forward, the strategy is now to strengthen the understanding of what the capabilities of the supply chain system design is. And if at all there's any issues that the ministry would feel that they would need to actually enhance the system, would actually build on already existing structure as opposed to starting from scratch on a new plate. Thank you, Edward.
Yeah, thanks, Gamariel. Great observation. And yes, sort of taking what you've got and kind of enhancing it and making it work better rather than starting over again, especially in the time of crisis or pandemic, is crucially important. So Suzanne, final question for you. If we could just briefly, if you could tell me a little bit about how PFSCM changed its operations quickly to come to grips with new suppliers and new products for COVID-19.
Yes, absolutely. So many of the environments that we work in are already complex. So again, when you add in the dynamic of COVID-19, it just exacerbates things. So some of the ways that we responded is to quickly pool our resources to focus on identifying alternative sources of supply. So I mentioned earlier, we saw many delays with products that we had been purchasing because of skyrocketing demand. We also had to deal with the implications of some companies not even being allowed to ship outside of their borders. So when you start dealing with those types of dynamics, we've got to start looking for alternative sources of supply quickly. And as a part of that, making sure those products meet quality standards and that suppliers will be reliable in fulfilling those needs. So really staffing up our resources within our sourcing team, looking for new technologies. So our Kodiak tool that I mentioned earlier has been a huge help in really being able to streamline coordination with our suppliers. So being able to get information proactively shared and really elevating the level of coordination and collaboration with our suppliers has really helped in that coordination. So we're also looking for other alternative types of technology that can continue to help us move forward and really streamline some of those processes. And then finally, on our 4PL side, that's another area on the logistics side where we really had to focus resources and change our way of operating. So whereas before you could usually set in contracts, work with partners, and usually have a fairly steady environment of operating, we're constantly evaluating our current partners and looking for alternative partners that can possibly help not only in the overall shipment of products, but also in niche areas. So it could be cold chain, it could be very complex and challenging lanes for distribution. All of those types of things are things that we consider now and are constantly evaluating. So as before, where you could possibly leave those and evaluate them on an ongoing basis, it's something that is much, much more highly coordinated. And we're constantly evaluating where we may need to make further changes to our partners and making sure we're bringing in new ones that can support those needs. So it's changed quite a bit, and most probably significantly as things that we experienced in the past, which were really exception-based management, frankly, has become the norm. So they're not exceptions anymore. It's just the standard way of operating. So I think those are things where we've had to adapt and realize both in our processes as well as in our tools that we're using, we need to be able to manage those types of situations more efficiently and faster, because it's no longer just an exception. It's just the normal way of doing business.
Great. Yeah, thanks so much. And great observation that the world has changed and we need to make sure we have the tools and processes to be able to change and respond to it. So great. Thanks so much. All right. Well, we are out of time and I would like to be sure we leave a few minutes for questions from the audience. So I would like to just thank all of our panelists so much for your presentations today and look forward to hearing what our audience has in store for us. Thank you very much.
All right, thank you so much to the presenters for that production. As I mentioned earlier, and I put in the chat, we won't have time for questions to the presenters. You can, however, type questions that you have in the chat, and folks have been doing so. The presenters will try to address them there. We're going to move on to the next presentation, the last presentation for this session. Malawi Ministry of Health and partners adapting the public health supply chain to swiftly and effectively distribute COVID-19 vaccines. My understanding is I think Charles is presenting, if I have that correct. So take it away, Charles. You're on mute, Charles.
Can you hear me?
Yes, we can.
Thank you so much, and welcome to the presentation from Malawi. I'll quickly take you through the issue from the Malawi Ministry of Health together with the partners in terms of how they were able to adapt the public health supply chain to swiftly and effectively distribute the COVID-19 vaccines. Next slide. So just as a matter of introduction, USAID in Malawi supports the Malawi Ministry of Health to respond to COVID-19 pandemic, basically through technical assistance, but also supporting the COVID-19 response. And this is being done in collaboration with other partners, basically to leverage the existing resources and enhance efficiency. Again, just to highlight that the USAID Global Health Supply Chain Program in Malawi manages a parallel supply chain system using third-party logistics. And to respond to the COVID-19 issue, the project quickly modified its contract with 3PL to accommodate storage issues and distribution for COVID-19 commodities, specifically issues of PPE, medicine supplies, and other ancillary products. Next, please. Malawi received its first shipment of vaccine doses in March 2021. And at the same time, we managed to solicit funding from USAID, totaling $500,000 which basically was used for provision of technical assistance, but also commodity warehousing and distribution. And this was achieved through working with the expanded program on immunization, which is basically a department of the Ministry of Health, to successfully implement the national vaccine deployment plan in or across the 28 districts in the country. And I'll quickly, shortly go through the areas that we supported. Next slide. So in terms of supporting the implementation of the vaccine deployment plan, there were a number of areas that the project supported the Ministry of Health. Firstly was the issue of coordinating logistics subcommittee at the national level, which enabled availability of information for decision making to be effective. We also supported warehousing and distribution of vaccines, as I said earlier on, to 28 districts. And it's important to highlight that this was done within the first 2 weeks of vaccine arrival. We also managed to redistribute some of the vaccines from areas where the uptake was low to areas where the demand was high. And this basically was to also help in terms of making sure that we address the stock imbalances, but at the same time, minimizing wastage through expiry. Next slide. We also supported the Ministry of Health to design guidelines for reverse logistics because some of the vaccines were not used and they had short expiry time. We ended up having some waste. So we had to quickly facilitate the development of the guideline to allow incineration of the vaccine waste. And this was done at the decentralized level using the various district health facilities. We also supported Ministry of Health in terms of enhancing its capacity through designing, printing, and distributing data tools to facilitate tracking of the vaccines. And we managed to configure the open LIMS, which is basically the existing electronic health commodity tracking system for vaccine tracking, reporting, and ordering. Previously, this was not part and parcel. The vaccines were not part and parcel of the products that were in the system. So we adapted it to suit or facilitate the tracking of vaccines. And at the same time, we also supported Ministry of Health in terms of training 66 staff so that they could facilitate the tracking, reporting, and ordering of vaccines. Next. Of course, there were a few challenges that we noted as we were providing support to the Ministry of Health. One was, of course, the low vaccine uptake, I think for a number of reasons, including issues of limited sensitization of people, but also there were a lot of issues on social media that were distracting people from taking the vaccine. Since this was the first time that we had introduced the vaccine to the populations. We also noted that as we're making efforts to support Ministry of Health, there were inadequate internal coordination issues because largely most of the key staff from Ministry of Health were not available due to other competing priorities. We did have also data at the very beginning of the pandemic, and as such, it was difficult to follow up what was happening in the districts. And as I said earlier on, this also contributed to the wastage through expiry of some of the doses, which eventually were destroyed. So just to qualify once again that the inability of the vaccine data tracking plus also low availability of data and the poor quality of data were some of the challenges that we observed. Next slide. Of course, we did come up with some learnings and solutions from the process that we went through. One of the key issues that came out is that redistribution was essential in minimizing wastage due to expiry. And this is something that has to be inbuilt as we move forward because it helps to move around commodities to where they are needed most. It's also important, we feel, to ensure that there's clear demand creation. For instance, there's need for deliberate campaigns to make sure that people are able to access the vaccines. And so that would also help in terms of reducing or avoiding expiry. We also noted that because we were able to work with other partners in terms of planning, there was significant efficiency that was gained, largely because we had joint planning meetings and there was a lot of sharing that was taking place among the various key partners. And so we were able to avoid duplication of efforts, but in the process, then we managed to fill the gaps where they were necessary. The existing open alignments, which we adapted to allow for tracking of COVID-19 vaccine, provides an opportunity for vaccine visibility as it cuts across the country. Various facilities across the country are using open alignments, and so the fact that we have been able to adapt it to allow tracking of vaccines gives us an opportunity for vaccine visibility and also sustainability for the future. Next. In conclusion, there are a number of issues that came out. One, or the most important, was that the operational flexibility that was there is critical in an emergency. As I said earlier on, this was an emergency and we were able to quickly link up with other partners and be able to plan together and move forward and leverage the resources. So because of this, there was effective and efficient vaccine rollout, but also there was enhanced warehousing and timely distribution of vaccines and ancillary supplies throughout the country. Next. We have also seen that because of the effort that we supported the Ministry of Health, we have strengthened their data management system for vaccine tracking, reporting, and ordering. So now they have insight and they're able to manage things better. We've also seen that because of the support that we provided in terms of developing waste management guidelines, we have improved waste management mechanisms for effective management of vaccine-related waste. But also we have ensured reliable and timely supply of COVID-19 vaccines to the last mile across the country. including those facilities that are normally hard to reach. Next, please. So essentially, that's what I wanted to present in terms of the support that we provided to Ministry of Health in terms of the vaccine distribution. Thank you for listening, and I welcome questions and comments.
Excellent, Charles. Thank you so much for that report. So folks, if you have questions that you'd like to ask Charles, you can hit that reactions button there in Zoom and raise your hand, and they'll give a signal to me to reach out to you. While we're waiting for that, Charles, I was wondering a little bit in terms of timelines, because this was all happening, you know, March 5th, the vaccines were coming in, you know, so when did you guys start the mobilization, you know, for the arrival of the vaccines, and give us a sense of like, what did you get done by the time the vaccines arrived? What was left to be done? And then, you know, how did you think about prioritizing what you were going to focus on as a way of being able to anticipate and execute when the vaccines arrive? Can I give us a sense of the logic and the thinking that went into the plan for how to deal with these vaccines as they were arriving?
Okay, thank you so much. So basically, planning, because it was an emergency situation, the planning took place within a couple of weeks. And like I said, we were quickly able to mobilize other partners, and you know, we had weekly meetings. So because we were meeting on a weekly basis, we were able to quickly make decisions and agree in terms of what resources are available. So every partner made you know, clearly spelled out in terms of what resources are available and that they can support. So it was basically a question of putting the resources together quickly within a couple of weeks. But as I said earlier on, the challenge was that at that point, the minister had already its plans, and because the staffing is low, it was difficult at the beginning to get the key staff from the Ministry of Health to make decisions, because there was no way we could move the program forward without the approval and availability of the key ministry staff, because our role basically was to facilitate and make sure that the things are working. So it was a bit challenging at the beginning, but I think within a couple of weeks, and because we're able to link up directly with the Ministry of Health, we were able to get the node and proceed with the receipt, the preparation for the receipt of the drugs.
Excellent. Looking to see if there are any other questions. I am not seeing any. So with that, Charles, I want to thank you for your presentation here. I think there's a question in the chat. Hold on a second. So the question in the chat, I don't know if you're seeing it, Charles. Monitoring and evaluation is a key process in ensuring performance management. What key system does the Ministry of Malawi implement to ensure visibility across all the levels of care, including primary healthcare remote areas?
All right, thank you so much for that. So the Malawi Ministry of Health has guidelines in terms of the health commodity logistics management in the country, which provide guidance in terms of how commodities should be managed. As a project, as the Global Health Supply Chain, we're supporting the Ministry of Health to manage the open LIMIs, which I alluded to earlier on. And this is basically the system that they're currently using to manage or track commodities. So they're able to collect the data from the health facilities through to the national level, analyze the data, and be able to use it for decision making, whether it's procurement of drugs, issues of quantification, ordering, but also distribution and redistribution where necessary. So when we had this COVID-19 issue, I mentioned as I was presenting that we used the opportunity that we already had a system that the ministry is using, which we are supporting, and we adapted that system so it can help us to track and report data from COVID-19 issues. And so basically, if we talk about the M1D, we're using that system, the OpenAI ones, to help us in terms of tracking the data, which then is being reported. Previously, we used to track on a weekly basis, but we noticed there were challenges because the current system is that the data is reported once a month. And so we changed the system, and now we are able to report about COVID issues on a monthly basis as well, just like the other products like malaria, family planning, MNCH, and also reproductive health. So we basically use the data because we continue to meet on a weekly basis. We use the data for planning and making further decisions.
Excellent. So I want to thank all our presenters, Charles, Johnson, Gamariel, and Susan for excellent presentations. It's up to you guys. And thanks to all the attendees for being here. And after this, actually, John Marie, did you have a? Oh, sorry, a couple hands now. Charlotte.
I think they're just applause. No,
Oh, they're just clapping. Sorry. Gotcha. All right. So right after this, we have the networking session that you're all welcome to attend and to connect. And I hope to see some of you there. And otherwise, I'll see you tomorrow for our last day. Thanks, everyone. Take care.
Thank you all.